Hello, welcome to Sonography-Radiology training channel. This series of videos is radiologic findings in fracture and dislocation of the shoulder. This is the fifth video in this video series with title of Posterior Shoulder Dislocation. The outline of this presentation include introduction, epidemiology, mechanism, radiologic features including plain radiograph, CT and MRI, associated injuries, ultrasound, reporting checklist, treatment and prognosis. At first, introduction. Posterior shoulder dislocations are far less common than anterior shoulder dislocations and can be difficult to identify if only AP projections are obtained. So, a high index of clinical suspicion is helpful. Epidemiology. Posterior shoulder dislocations account for only 2 to 4% of all shoulder dislocations, and the vast majority are anterior dislocations. Mechanism. Typically, the humeral head is forced posteriorly in internal rotation while the arm is abducted. In adults, convulsive disorders are the most common cause. Electrocution is a classic but uncommon cause of posterior shoulder dislocations. In both situations, bilateral dislocations are not infrequent. Occasionally, they can be the result of strength imbalance with the rotator cuff muscles. Posterior dislocations may even go unnoticed, especially in elderly patients. Radiographic features. Plain film series usually suffices in making the diagnosis, although cross-sectional imaging, CT or MRI, is often used to assess the presence and extent of articular surface injury, for example, reverse Hill-Sachs defects, galenoid injury like reverse Bankart lesion, or ligamentous injury. Ultrasound is uncommonly used, however may be useful in the emergency setting. Plain radiograph, CT and MRI findings. Posterior dislocation may be missed initially on frontal radiographs in 50% of cases as the humeral head appears to be almost normally aligned with the galenoid. An axillary view is preferred view for the diagnosis. A Walpo, Wallace or modified trauma axillary view is an alternative. But we must know that a scapular Y view has been shown to be unreliable for diagnosing posterior shoulder dislocations. Radiographic findings include absence of external rotation on images in a standard shoulder series, light bulb sign, trough line sign, loss of normal half-moon overlap sign, rim sign, and acute angle of the scapulohumeral arc or Maloney's arc. Absence of external rotation on images in a standard shoulder series is a clue. As you know, for take an AP shoulder X-ray, we ask the patient to do external rotation. But in a patient with posterior shoulder dislocation, the patient cannot do this external rotation. Another X-ray finding is light bulb sign, due to fixed internal rotation of the humeral head, which takes on a rounded appearance. The light bulb sign refers to abnormal AP radiograph appearance on the humeral head in posterior shoulder dislocation. When the humerus dislocates, it also internally rotates such that the head contour projects like a light bulb when viewed from the front. Trough line sign. In a posterior dislocation, the anterior aspect of the humeral head becomes impacted against the posterior galenoid rim. With sufficient force, this causes a compression fracture on the anterior aspect of the humeral head. As you can see in this, we have light bulb sign and also it's associated with trough line sign. Trough line sign is a vertical line made by impression fracture of the anterior humeral head. This compression fracture is analogous to the Hill-Sachs compression fracture seen with the anterior shoulder dislocation to the galeno-humeral joint. Frontal radiographs reveal two nearly parallel lines in the supromedial aspect of the humeral head. Another X-ray finding is loss of normal half-moon overlap sign. On a normal true anteroposterior image, there is a half-moon overlap between the humeral head and the glenoid. But in a posterior dislocated shoulder, there is a lateral displacement of the humeral head with respect to the glenoid, causing the losing the half-moon overlap sign. As you can see in this image, there is lack of the overlap between the glenoid and the humeral head, and the shoulder is rotated such that the humeral head has a light bulb appearance. Another radiograph finding is rim sign, means widened glenohumeral joint more than 6 mm. Another finding is acute angle of the scapulohumeral arc or Molini's arc. It's analogous to Shenton's line of the hip. It's delineated by inferolateral scapular margin to the medial proximal humeral shaft and superior migration of the humeral head. Rotator cuff insufficiency can cause disruption to this imaginary radiographic line. When there is posterior shoulder dislocation, Molini's arc also present and can be used to distinguish from the anterior dislocation. As you can see in this patient with anterior shoulder dislocation, the Molini's arc cannot be delineated. Associated injuries. The first one is reverse Hill-Sachs defect, also known as McLaughlin lesion, is defined as an impaction fracture of anteromedial aspect of the humeral head following posterior dislocation of the humerus. This axial CT image shows obvious reverse Hill-Sachs defect, as you can see here. It's of surgical importance to identify this lesion and correct it to prevent osteonecrosis. On plain radiograph, CT and MRI, the lesion is characterized by loss of the normal convexity and a wedge defect in the anteromedial aspect of the humeral head, in contrast to Hill-Sachs defect which occurs in the superlateral margin of the humeral head. You can find full explanation about Hill-Sachs lesion in this video. Another associated injuries is reverse Bankart lesion. Is defined as the detachment of the posterior inferior labrum with avulsion of the posterior capsular periosteum. This lesion leads to laxity of the posterior bond of the inferior glenohumeral ligament with posterior displacement of the humeral head. As in the case with the Bankart lesion, the trauma may be severe enough to involve the bony glenoid, resulting in an accompanying small flake fracture. You can find full explanation about Bankart lesion in this video. Another associated injury is proximal humeral fractures, in particular fracture of anatomical neck and or lesser tuberosity. Another associated injuries are posterior Hagal lesion, means humeral avulsion of the glenohumeral ligament, posterior labrocapsular periostal sleeve avulsion or Plopsa lesions. Ultrasound. Point-of-care ultrasound can be utilized in the emergency department, particularly in situations of non-diagnostic radiographs when CT is unavailable or in patients who have had recurrent dislocations. The transducer is placed posteriorly on the shoulder using the humeral head position relative to the glenoid rim as the anatomical landmarks. Reporting checklist. In addition to stating that a posterior dislocation is present, any evidence of proximal humeral fractures should be thought and commented on. Now, a few points of treatment and prognosis. In most cases, acute posterior dislocations have spontaneously reduced prior to imaging. When a posterior dislocation presents to the emergency department, unlike anterior shoulder dislocations, which are relatively easily reduced, posterior dislocations are more problematic and attempts at close reductions should be performed in consultation with a treating orthopedic surgeon. Additionally, if the shoulder has been dislocated more than 3 weeks, particularly common in debilitated elderly patients, or if the anterior humeral articular injury, for example, river Hill-Sachs defects, involves more than 20% of the articular surface, then the close reduction is contraindicated. Fortunately, new vascular compromise is uncommon, but associated glenolateral and capsular injuries can lead to posterior shoulder instability. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.